Yeah, hi. So my name is Maureen Nash. I'm an internal medicine physician and a geriatric psychiatrist. And I have been asked to talk to you today about personality disorders. And it is a very broad and deep and somewhat controversial subject. So I'm going to do my best to focus on issues that are pertinent to older adults. Um, I I have no financial conflicts of interest. Um, and I just want to first start with some of the challenges. Half of the people who meet criteria for a personality disorder meet criteria for another one, which indicates that our criteria aren't particularly good. Some of these things that have been described for centuries are actually very rare, but might be interesting. So medical people write about them. Many people who have serious personality problems don't actually meet criteria for a diagnosis. And then finally, if you have 5 different people with the same personality disorder, they can look really different one from another. All of which suggests there is some fundamental challenges that we have with just the entire concept. That being said, we do know that people have problems with other people. They have problems with their sense of themselves and their inner emotional life, and they have behavioral problems that impact lots of people around them. And some of those folks have long-standing and lifelong problems. And so that is the group of people that we say have a personality disorder. And I just want to highlight a couple parts of the definition that are really important to understand. You don't get a personality disorder late in life. Personality disorders have symptoms and behaviors and feelings that are the same as all the rest of us, but they're more extreme and they're inflexible, and they pervade their entire life. So they have these persistent maladaptive patterns. And some of the common things that people with personality disorders share is either an unstable positive sense of self, or in a few cases, just an overwhelmingly positive sense of themselves that few other people share. Nearly everyone who has a personality disorder is unable to sustain close relationships. So if you get to be older and you actually had a long-standing successful marriage, or you have had long-standing close relationships, it actually makes it pretty unlikely that you have a personality disorder, even though you may now have lots of symptoms that look like personality disorders. And there is always a cultural aspect to this. You really need to know what culture a person is coming from if you want to have a sense of what's quote unquote normal and what's not normal. Because a Native American culture is different from an Asian culture, is different from a Australian culture, is different from a British culture, is different from a Russian culture. So what might look normal in one place looks very abnormal in another. One of the key things about the definition of the disorder is that it has to impact at least 2 areas: cognitions, moods, interpersonal functioning, and impulse control challenges. And another part of the definition is that personality disorders are not due to another mental illness, another medical condition, or a substance use disorder. And that's one of the key points. There are many, many people who end up with a personality disorder on their problem list, and they have multiple other psychiatric diagnoses on their problem list. Generally speaking, most likely what they have is the psychiatric illness on their list, and then they have maladaptive behaviors that have led others to conclude they have a personality disorder. I wanted to just give you some of the official definitions that when we're talking about personality disorders and cognition, what we're really talking about is a person's way of perceiving and interpreting themselves and others, as well as the events around them. It's the understanding and being able to interpret social signals about what other people mean or intend, what other people are feeling, so that you can have reciprocity, being able to interpret events that happen relatively objectively instead of always that events are always about you, or they're always about others, or that they have some nefarious intent. Affectivity or emotions, so the range, intensity, the way emotions move from one to another, and the speed with which emotions change, as well as the appropriateness to the situation at hand. Interpersonal function, the ability to empathize with others, the ability to compromise, to love, to be loved, the ability to work together. So that's another thing. People who actually have a moderate to severe or severe personality disorder often have never had a successful job. And most older adults, frankly, have had successful jobs and or successful marriages. So again, they may have challenges when they get to be old, but it might not actually be a true personality disorder if it's not lifelong. Impulse control problems are a key part of several of the personality disorders. And again, it may represent a personality disorder problem. It may represent something else. So if you're going to talk about personality disorders, what's a healthy personality? So generally speaking, we are thought to have healthy personalities when we are flexible, adaptable, our personality is stable over life and predictable. Other people can predict, generally speaking, how we're going to react. Whereas sort of an unhealthy personality is thought to be rigid, maladaptive, and it causes significant distress to the person and those around them. And this is sort of one of the controversial areas around personality, because many of us are fairly flexible and adaptable and predictable, but let's say some horrible crisis just happened. Our loved one got killed in a car accident or some other really unexpected event. Well, we might not be at our most adaptable, flexible, and stable at that point. You know, one of the things they talk about with severe grief is there is no real such thing as normal grief reaction. A severe grief is by definition unpredictable, and what's normal is quite varied. So this is sort of all part of the subjectivity of this. And we still get to the well, if I know it, I'll know it when I see it, which a lot of clinicians sort of live in that kind of world. When we look at personality disorders, we divide them up into 3 different clusters. So there's cluster A, or the odd eccentric cluster, paranoid personality disorder, schizoid, schizotypal. There's cluster B, the dramatic, unpredictable, and emotionally unstable group of personality disorders, antisocial, borderline, histrionic, and narcissistic. And then there's cluster C, individuals who are very anxious and fearful, including avoidant, dependent, and obsessive compulsive personality disorder. But so are personality disorders, are they really illnesses? Well, are they related to other illnesses? Well, it turns out cluster A personality disorders are much more common in those who have relatives with chronic psychotic illnesses like schizophrenia. Cluster B, so cluster A was sort of the odd eccentric cluster. Cluster B, which was the emotional lability and dramatic kind of personalities, those are more common in people who have relatives with mood disorders. And then cluster C, the anxious, needy kind of cluster, is more common in people who have relatives with anxiety disorders. And that all suggests that there's some underlying genetic component to personality disorders. And despite this being a topic that has been talked about for hundreds of years, we're still really in the infancy of understanding personality disorders. But the reason I just wanted to mention these correlates is one way to think about personality disorders is that they are sort of attenuated and have overlap with some of the more severe psychiatric illnesses that some people have. But maybe they just don't rise to the level of meeting criteria for a psychiatric diagnosis outside of the personality disorder realm. Just going to touch base on normal aging because we're talking about personality disorders in older adults. Well, like everything else, we age individually, but there are some common things. Attention is much slower in normal aging. And it's much more difficult and takes more energy and time to switch our attention from one topic to another. So older adults don't do well when multiple things are thrown at them all at once. They really do better if they're presented with information, one topic at a time, with lots of time to allow them to process it. However, once they're engaged and they're paying attention to something like watching a movie or reading a book, their sustained attention, that's the same as when they were younger. And some people are better at sustained attention. Those of us who did well in school usually have pretty good skills in that area, whereas others are less skilled in that area. So it's for that particular person, it'll be the same as when they were younger. And then working memory. So memory is amazingly complex and there's many different parts of it, but working memory is sort of all the things you have to keep in your head at once when you're trying to formulate thoughts and plans. And that is very impacted in aging. And so it takes more energy and more time and more attention and fewer distractions for older adults to form and use their memory. Vision and hearing problems are common in older adults. However, there are some things that they do better. Their ability to debate, their vocabularies are better. Their conversational skills are often better. I myself find older adults the most interesting people to talk to, which is why I went into geriatrics. There also are some differences in decision-making. Older adults are more likely to rely on experts, which works out well for me as a physician because people see me as an expert sometimes, which is really a different strategy than younger adults. Younger adults are far less likely to sort of have respect for the older expert, and they're more likely to try and figure out different ways to make decisions, different ways to figure out what's the right next thing for them to do. And parents see that all the time, right? Sometimes they just do the opposite of whatever you said. And then executive control. So that's sort of the part of our brain that's the CEO of our brain. And there is age-related decline with that. And it depends on your ability to pay attention. It depends on your memory. It depends on your decision-making. It depends on having accurate perception and good speech and language skills. So all of the other small deficits can impact executive functioning. So the CEO, when we get older, has a much harder job to do. And successful aging, it turns out, isn't about the bad things that happen, but it's about the good people who enter our lives. And one of the interesting facts about successful aging at any age is that a single relationship with another human being can actually change the course of the rest of a person's life. That's true for children, and it's true for older adults. So never underestimate the impact that your relationship, no matter how constrained or short term it is, how much impact you can have on another human being, for good or ill, as it turns out. And one of the interesting things to me is that it turns out that knowing how to play and create and sort of use that part of our brain turns out to be more important than income in retirement. Obviously, that's true if you have sort of a basic level of income. If you have no income at all, you're not going to be able to spend very much time learning how to play or create. So I guess the magic number is $75,000 or $80,000, they say. Any money above that doesn't actually help people be happier. A good marriage at 50 predicts positive aging at 80, while low cholesterol doesn't. All the cardiologists out there might sigh. Alcohol abuse is the number one thing that is most destructive to social relationships. And then subjective good health is much more important than objective good health. So it's not really how many chronic health conditions I have, it's what I think about them and how I think about them that actually will correlate to success. So what about personality traits? We all have personality traits. And if personality traits are causing the person problems, but they haven't been present throughout their life, by definition, it's not a personality disorder. And we all have some more adaptive and less adaptive personality traits. If you are interacting with an older adult and you're thinking, geez, this seems like somebody who has a personality disorder, but they've also had all these long-term work or personal relationship successes in their life, then really what you want to start thinking about is other things like neuropsychiatric disease, dementia, traumatic brain injuries, vascular injury from things such as stroke, substance use and substance use disorders, and then misinterpretation of serious mental illness or chronic psychotic illness. Sometimes, and actually frequently, those symptoms kind of mellow and decrease in severity as people age. And so what I have seen a lot of times is people who have a serious mental illness still have some residual symptoms, but it doesn't impact their life the way it did when they were in their 20s. And they end up with a personality disorder on their problem list when really what people are seeing are kind of residue of their serious mental illness. But whether it's these personality traits are caused by a personality disorder or a trait, there actually are some very standard tips and ways of approaching people that will help us help those who have maladaptive traits. And sometimes when we can recognize maladaptive traits in ourselves, then we can use some of these tips on ourselves if we're able to see it. So I'm going to just go through some of the real common personality traits that we see in older adults. So paranoid traits are generally speaking relatively common. And one of the things about paranoia to know about people who have paranoia is, you really want to work with that person one-on-one. It's much harder for a person who is interpreting events and people around them as dangerous. It's very hard for them to be in a group setting because then they're going to be much more defensive and they're going to be spending all their energy paying attention to potential threats rather than being able to process information you might be trying to convey. It's always important not to directly confront paranoia. My screening question for paranoia in care facilities is usually, how is everybody treating you here? which is obviously a very indirect question. I always start with indirect questions and become more direct over time if a person can tolerate it. If you think that someone is misinterpreting things in a paranoid way, it is exceedingly important that you be as honest and clear, straightforward as possible, and shorter explanations, leaving time for questions so that you can help the person sort through what's real and what's not, what's a threat and what's not. You want to clearly explain what you're doing and what will happen. When I am working with somebody who's paranoid, I will often literally I will describe what I'm doing as I do it. I'm going to take my stethoscope and I'm going to put it on your chest, and then I put my stethoscope on their chest. I'm going to lift up your arm and test your muscles. I verbally describe every single move that I make before I make it, so that they're not surprised. And we all accidentally are dishonest or misrepresent or misunderstand things. So when you're dealing with somebody who's paranoid, it's very important to be honest and admit a mistake when there is one, and sometimes taking responsibility for a mistake even when you weren't the person who made it. Your goal is to support the person to function better. People who have paranoid traits do not really benefit from a warm, fuzzy style. They do much better with somebody who's professional and treats them, with really solid boundaries. It's really important not to react to people who are paranoid with defensiveness, fearfulness, or to reject the person. And there is some evidence that low-dose antipsychotic medication can be used intermittently for people who have paranoid traits. What about schizoid traits? Those people who are kind of withdrawn, not interested in close relationships with others. So it's not somebody who wants close relationships but can't have them, but somebody who's just not interested. Those people generally, they benefit from some role playing, from problem solving therapies, really helping people work step by step, so that not so that they can learn to be close to other people, but so that they can learn to move through life and get done what they need to get done. So cognitive distortion therapy can be helpful, like cognitive behavioral therapy can be helpful if a person doesn't have dementia or that kind of neuropsychiatric illness. It's important to understand people who have schizoid traits. They tend to really need lots of alone time. They need to have a safe space where they can go and just be separate from the stimulation that comes with other human beings. So minimizing new things can be very helpful for these folks. When you're interacting with people, it's important to have a very quiet, reassuring, and considerate stance. And recognize that you may not be able to, we all kind of read the emotional state of people when we're talking to them, and it helps us communicate. In people who have schizoid traits, you may not be able to read their emotional state, but it doesn't mean they're not having feelings. So don't make assumptions that just because people aren't having an overtly emotional reaction, that they're not actually internally having feeling states. And if you want to know, you can just ask how people are feeling. Schizotypal traits, that's sort of the odd thinking person who has a lack of close friends. This is the kind of person you want to avoid any sort of sarcasm with. You don't want to ridicule or judge them. Again, the quiet, reassuring, and considerate clinical stance is important. You want to expect that people are going to misperceive and be ready for it, and to give short, brief explanations, and sometimes you just have to agree to disagree. And don't become impatient with limited progress. Remember, the key here is what are their goals, not what are your goals. So there's a lot of overlap with the schizotypal and schizoid. Antisocial personality disorder, it's in the movies a lot and on TV, gets a lot of press. It's very rare. Frankly, people who have true antisocial personality disorder don't age. They either suicide, die through an accident or poor decision making, or die from homicide. I mean, they're just not very commonly seen in older adult. And some people sort of age through it and manage to learn how to interact and have fewer problems around this. So by definition, it has to present prior to age 18. One of the things we can see in this is people can shift to sort of excess somatization, excessive focus on physical symptoms. It's really important to reward any positive behaviors you see. That's just general good advice anywhere. You want to help people draw connections between actions and feelings. Groups can be helpful for people with antisocial personality disorder, but only if they're with a whole bunch of people who have the same kind of outlook on life. You don't want to put a person with antisocial personality in a group full of, say, dependent people. That is not going to work well. So you want to set firm limits. You want to not prescribe medications for personality problems whenever possible. And it's really important to keep the rules with this particular group of people. Borderline personality disorder, I think, gets the most press. It's the most common diagnosis seen in medical settings. So there's some people who have personality disorders that are almost never seen in a medical setting, not because it doesn't exist, but because they don't perceive that they have a problem. People with borderline personality disorder suffer greatly and want help. And that's part of the reason why they keep coming back to medical settings, even if they're asking for help in ways that are unlikely to help them. It's actually thought that it's an emotional developmental delay. And many people age out of and evolve emotionally out of borderline personality disorder. So some of the stats, generally speaking, by age 30, 10% of people with borderline personality disorder have died by suicide. Within 2 years of diagnosis, only 44% in one very large study still had symptoms. After 27 years, so if you're 20 years old, after 27 years, so you're 47, only 8% of people who were diagnosed with borderline personality disorder still had symptoms. So you can see why that makes it really challenging to call this a personality disorder, because by definition, that's a lifelong thing. There are significant impairments in conflict resolution, impulse control, and decision-making. And I want to highlight that because those are really common impairments in people who have dementia: conflict resolution, impulse control, and decision-making. And in fact, all older adults have some problems in decision-making. So I think a lot of people older adults end up being labeled as having this because we as staff feel like we're being manipulated, and that it becomes shorthand for the diagnosis sometimes. So one of the things I point out to myself and others is that, I might feel like I'm being manipulated, but that does not mean someone is trying to manipulate me. What we call manipulative behaviors, generally speaking, is someone with very poor coping skills who's trying to get their needs met in as best they can, even though it's a relatively dysfunctional way. So when someone has borderline traits, there's certain sort of rules of the road that help us. You want to accept the person for where they are. You want to encourage them that they can change. You don't want to try and change them, but you want to support them and just let them know change is possible. It's hard. It can take time and effort, and sometimes change is painful, but it is possible. and you want to really sort of imagine yourself as being the calm, stable home base that a person can come back to as they try and learn to cope with the world. It's important to be as fair and consistent as you can. The more communication, the better. And when you're having a particularly challenging time with someone and feeling very distressed, which often happens when we deal with others who are very, very distressed, sometimes it's helpful just to remember, well, as bad as I feel, they still feel way worse than I do. And I get to go home from the office to my family at the end of the day, whereas they take themselves with them wherever they go. One clinical key is treat all other mental illnesses and substance use disorders with evidence-based medications and interventions. You don't necessarily want to treat the impulsive borderline traits that you see, most of which don't respond to medications, but any other illnesses or substance use disorders they have, you do want to treat. I'm gonna talk a little bit about suicide, because this is what we all worry about. We spend lots of time thinking about it and documenting on it. Suicidal ideation or thoughts of suicide, most of us rarely, or maybe once in our life or even never, have thoughts of killing ourselves. But there are people who have chronic suicidal ideation. They think about killing themselves every day. And in fact, it's very helpful to them. When you're really suffering terribly, knowing that you have an out is important. And that is how some people view suicide. And so it's like, well, if things become totally unbearable, I can kill myself. Actually, killing oneself is much harder than it might seem. And many people are not particularly successful at doing it. And the people who have a past suicide attempt, people who have chronic suicidal ideation are at risk of killing themselves. But one of the things we want to think about is this suicidal ideation, is it part of their coping style? And if it is, you have to be really careful about doing something you don't want to take away their coping unless you've given them something else to cope with unbearable suffering. So suicidal ideation is not a great treatment target per se. People actually doing things to harm themselves is a much better target. And thinking about killing yourself doesn't actually mean you are at high risk of killing yourself. There are many, many risk factors for suicide that are fixed, and you can find them in any article on assessing people for suicide. The biggest risk factor is actually family history, having a first-degree relative. And obviously, if you have a family member who's killed themselves, there's nothing you can do about it now. So the key things to look for in an interview, if you want to know if someone is really at risk of suicide, you want to look for, do they complain of severe, relentless, unbearable pain? Are they telling you that they have severe insomnia, they haven't been able to sleep, they look horrible, they look like they haven't slept, and they tell you it's unbearable? Or are they pacing and having significant psychomotor agitation? Those are the three things you can see in an interview that are acute risk factors that are modifiable. Those are things that when you think somebody is at high risk of suicide, that you might want to treat aggressively. The two people who I was the last clinician to speak to before they completed suicide had one factor in common, and they had this dense hopelessness. I mean, you couldn't sit with them without, or at least I couldn't, without sharing in just this total lack of hope. And so for me personally, that's one of the things that I always look for and and document when I'm doing a suicide assessment. One of the key things for people who have trouble coping, so people with personality disorders or maladaptive personality traits, one thing that does seem to be a lifeline to people is believing that there's somebody who truly cares about what happens to them. It's important not to have poor boundaries and violate your boundaries, but knowing that somebody cares about them often is what stops a person. Nearly everyone who kills themselves has a certain amount of ambivalence about it. So, which means, you know, they think about the pros and cons of it and how it'll help them more than it would harm them to kill themselves. And when people are actually sort of at the end of their rope, they actually can't see anybody else. So they're not going to, somebody who is totally suicidal and hopeless is at a spot where they can't even think about their children or their spouse or their parents. And so they can get to that point where knowing that somebody else cares about them isn't enough. But for people who are not quite at that point, it's a really important thing. Just going to touch on narcissistic traits. I have not found any way to successfully help people change those traits. Those folks don't think that they have a problem. They think, the rest of the world has a problem. But key things for older adults is these people are really at high risk of, these people who have these things, these narcissistic traits are at high risk of a severe midlife crisis, and they're poorly able to tolerate becoming old or disabled. So that's actually when they are at highest risk of killing themselves, is when this is the kind of person who gets a terminal diagnosis or who stops being able to do what they used to do. It's important for these folks to know that you respect and appreciate them. When they are misunderstood, when they feel misunderstood, they can become irritable or enraged. They do not tolerate criticism in any way, because if you're criticizing them, obviously you have major problems. They're often seen as demanding. They demean others. And so you want to, as a clinician, you want to avoid becoming angry or defensive. And sometimes you just have to walk away for a bit and come back if you're too distressed yourself. I'm going to briefly go through, at crisisprevention.com, they have a really nice guide that you can download for free if you register at their site. And it's about crisis prevention. It's a guide that actually works with both children and older adults and probably everybody in between. It's a training for the language of behavior, helping you recognize behavior as communication, helping you prevent behaviors from escalating, helping you respond appropriately. So I'm just going to very quickly just slide through these, and the references in there and the slides are here. So please feel free to spend more time with them. They're really kind of, in some ways, common sense, but it can be really helpful to review it from time to time. Be empathic and non-judgmental. Try not to discount other people's feelings. Recognize that somebody may feel attacked, somebody may feel like you're threatening them. That doesn't mean that they are being attacked or you are threatening them. So feelings aren't facts, but they're still very real, and they cause lots of stress and pain to the person who has them sometimes. Keep in mind that whatever the person is going through, even if it doesn't seem like it should be that important, if they're telling you it's the most important thing in their life at the moment, it probably is. Respect personal space, always very important when you're interacting with people who are in the midst of a crisis and escalating. You want to really be as non-threatening with your personal actions as much as possible. Your tone, your body language, moving slowly, being mindful of your facial expressions and gestures, giving people in time to interpret. Avoid overreacting. Think to yourself, I can handle this. I know what to do. Even if you aren't quite sure what to do right this second, overall, you're a professional. You've got to this point. So having faith that you can maintain your own rationality and be calm turns out to help you do exactly that. Focus on a person's feelings, not their words. You want to look for the real message, and then you want to empathize briefly and concretely with the feelings. You want to be supportive of the feelings, and you really want to ignore words and sometimes actions as much as you can. And this one is really hard, especially for physicians. Not all physicians, but at least I've had some challenges with it. You want to ignore challenging questions. You don't want to get into a power struggle. So when a person is just challenging your authority to be there, to speak, to do this or that, you want to redirect attention to the issue at hand, because it's not about you. It's about whatever the crisis is at hand. You want to ignore the challenge that people give to you, but not the person. You want to focus on problem solving together. It's important to set limits respectfully and concisely. Remember that people who are really upset aren't going to focus on everything you say. So you need to really, the less said, the better sometimes. You want to speak simply. You want to offer positive choices. You want to offer, let's do this. Do you want to do that? Rather than, you can't do this, you can't do that. Choose wisely what you insist upon. Really be careful when you say something is non-negotiable. Offering people options and flexibility often helps de-escalate. Allow time. You don't have to keep talking, even though I've kept talking here for 42 minutes. Believe it or not, silence is one of our most powerful communication tools. Finally, allow time for decisions. When a person is upset, they just aren't going to be at their best. They aren't going to be able to think through everything you've said easily. And the more stressed we are, the longer it takes. So slowing down and being in less of a rush. And I know, like, there's certain circumstances, like being in the ED, that's one of the hardest things ever. In the medical profession, time is a very precious resource. So it's very challenging, but it is very important. So I see a couple questions. Anxiety can be long-standing and pervasive. How would you weigh the symptoms to come up with an anxiety disorder, such as generalized anxiety disorder versus dependent personality disorder? Well, what I will tell you is the criteria for generalized anxiety disorder are clear-cut and valid and reliable. So if a person, you just pull out your DSM, go through it and look to see how close a person matches it. If they had that if they had that at some earlier point in their life, but they're still having symptoms of it, it's more likely to be a relapse of that than it is to be a personality disorder. That being said, some of the techniques to help people with dependent personality traits can be helpful for people with generalized anxiety. So working with people with personality disorders requires learning a certain style of interacting with others, which is kind of different than the manualized treatments we have for mental illness. Nirmala Dar, who often has great questions, says there appears to be a gender bias with certain personality disorders. In particular, borderline personality disorders, there are more women, and antisocial personality disorders, there are more males. Well, I will tell you that that is borne out in research for those two personality disorders and a little bit for some of the other ones. Why that is, well, when I get my Nobel Prize, I could probably answer that. I suspect one of the most interesting studies was that men who had antisocial behavior disorder, when they were hospitalized, personality disorder, antisocial personality disorder, when they were in prison, their behavior was much more like borderline personality disorder, people with borderline personality disorder. So it might just be some of that might be gendered by society and other influence. But I think, and with major depression, so the interesting thing about major depressive disorder is that up until age 55 to 65, women far outnumber those with major depressive disorder, but for older adults, 65 and up, it's more like 1-to-1. So the gender differences that we see in people who are younger often fade with time. So I see I'm getting questions in multiple formats here. I will make sure that Angela has an up-to-date list of all my slides. I had heard that there is a higher proportion of older adults with personality disorder in senior living because they don't have good relationships with family or neighbors and cannot be successfully aging at home independently. I have not heard that per se, but what I will tell you is people end up in senior living facilities like assisted living or residential care facilities or memory care facilities or nursing facilities. They end up living there usually because they have ADL needs, and either the people in their life, they're beyond what the people in their life can do, or they're beyond, or those people have died. So people often outlive their support systems. You definitely see that with children who have disabilities. Their parents take care of them for years and years and years, and then their parents die. What I would say is I think there's a higher proportion of older adults who have neuropsychiatric illness, cognitive impairment, and dementia. And those neuropsychiatric illnesses can present with things that look like personality disorders. I don't actually think that most people with personality disorders, if it's a severe personality disorder, they don't live to be old. And those that do often have very attenuated symptoms. So I think what people tend to look at and see the poor coping skills that you see in people who are living in assisted living, residential care, and memory care are because their brains are broken because of neuropsychiatric illness. Oh, Nirmala wants the article. I will look for that. So Patrick, did you have a question? If you type the question in, I'll do my best to answer it. All right, so Patrick Brodigan, what a nice Irish name. I'm not seeing the question. Aha. In long-term care, where shift change is a factor, how does one provide the consistent support? That is an excellent question. I think there's a couple things. I think, and it really kind of depends on the personality traits, the cognitive function of the person you're serving. But what I would say is people who are anxious and dependent do best with having a single contact person that they can go to when they're stressed. So those folks do well when they have like one, maybe two, but staff people who they always go to and who help interpret the staff for them, and who help them by explaining them to the staff, to other staff members. Whereas there are other people who have sort of behavioral challenges that really, and they aren't helped by having a single point person. That's the kind of situation where you really want everybody on the shift to be on the same page. And you want to figure out how to really start the shift with good communication shift to shift about what's going on for that person that day. Person-centered care planning is really, really important. And one of the other things that's important with older adults that I think we really underestimate is letting them be the expert in something. So if you have somebody who walks around and who's always criticizing, can't find anything right about anything, if you can get that person to be in charge of something, like developing an orientation program for new residents, or developing a complaint form for other residents to use, something, allowing an older adult. One of the horrible things we do in this country is we make people, we take away all their ability for meaningful goal-directed activity. They work, they're an expert, people come to them, they have a job, and then all of a sudden they don't. So anything you can do where you can show that you're valuing that person's opinion. Heather is asking, how important is insight into personality diagnosis for older adults? Is it helpful for them to have knowledge and working understanding? I would say, generally speaking, no, because what you're really usually dealing with are personality traits and not actually personality disorders. For many people, you can offer them opportunities to learn better coping skills. But I think personality disorder labels are really, generally speaking, kind of condescending and don't serve us well, and certainly don't serve people who we think have them well. So I think it's much more important for staff to recognize traits, and then recognize that this is not something a person is choosing to do, and they have limited control over their ability to change. We want people to change lots, but in fact, older adults have increasing health problems, have cognitive challenges, and really we need to change. Staff need to change, and not the person. And I'm being told my time is up.
Thank you, Dr. Nash. As always, we appreciate you giving us this time and a wealth of information.